Great. Thank you so much, Shannon. Really great to be in a virtual room with all of you today. Just like Shannon said, I'm a family doc. I work with Idaho Department of Correction. I currently am detailed out to the Bureau of Justice Assistance to do some work specifically focused on substance use disorder and reentry needs for folks who are leaving prisons and jails, which has been great. So today, just like Shannon said, my thoughts are that because 95% of people who are incarcerated in the US return to our communities, we can and should all be thinking about ways to make that reentry as safe and effective as possible. And by safe and effective, I mean keeping people alive and helping people thrive, and making sure that people have all the resources that would help them not return to incarceration. I will also say that of the people that I've gotten to talk to in this room before, which there are quite a few of you, this is near and dear to my heart. And if you have any questions or thoughts, I hope that this is a conversation. So please just jump in, and I'll rely on Shannon and the ECHO team to just say, stop talking. Someone has a question, or please look at the chat. Please, I want this to be a conversation. Okay, next slide, please. So I don't have any disclosures, but objectives for today. I hope that you all walk away feeling like you have a better understanding of the risks that are specifically healthcare associated when it comes to reentry, and reentry being, again, releasing from prisons or jails, that we can identify some of the barriers that exist currently that make it difficult to prioritize healthcare at reentry, and that we can focus in on a few populations specifically who would benefit most from healthcare reentry support, just knowing that our resources are limited, and who can we make sure are at increased risk of recidivating or increased risk of using the ER, increased risk of death. Who are those folks, and how can we get them the resources? Next slide, please. So the numbers, we have 650,000 folks that release every year total from prisons. And then there are 9 million people / separate entries and exits from jail in the US, which means that we have almost 10 million opportunities to make reentry better, which is pretty amazing to think about. In the 2 weeks, not yet, thanks. In the 2 weeks following release, this population that is reentering our society experiences more emergency room visits, more hospitalizations, and has a 12-time greater risk of death, which also includes an over 100-time greater risk of death by overdose. And so those 2 weeks post-release are, I would say, the most important to really make sure that people have access to the healthcare that they need to, again, survive and hopefully also thrive. Next slide, please. And I wanted to give you some information for folks that might work adjacent to correctional spaces or have not yet had experience working with people who are justice involved. But I'm guessing that most of you on this call have worked with people who have been incarcerated. But in the state of Idaho, of the 13,000 residents at any given time in our state that are locked up, the majority of them are in state prisons. And you can see about a quarter of them are in local jails. The use numbers, I think, are actually even lower than this. So it's a use of 390, and I think that number is lower. So my apologies for that. We don't have any federal prisons in Idaho, but this is Idahoans who are locked up in federal prisons. Okay, next slide, please. So, like I said, goals of reentry. There are 2 goals. The first is supporting reintegration into community. And then if you could forward again, please. And then the next one is to really avoid recidivism. So what is recidivism? Recidivism means returning to prison or jail. Unfortunately, in the first 5 years post-release, 75% of people will return to incarceration at some point in time, whether or not that's a one-day stay in a jail or a new sentence that they're serving. But again, focusing on the need, 95% of people will release from prison or jail. So we really need to focus on the reentry. And the community impact on this, 100%, I would say, everyone will take care of someone that's impacted by a justice-involved individual at some point, whether or not that's working with a client who is formerly incarcerated working with a family where a parent is locked up. I mean, you all have seen this within the foster system, definitely. And so how can we make sure that we're really addressing the needs of our community? Thinking about the health risks that exist for people who are justice involved, people who have experienced incarceration are 9 to 10 times more likely to have a diagnosis of hepatitis C, almost the same likelihood of having a diagnosis of HIV. Their asthma risk is higher. Their severe mental illness risk is higher, significantly so compared to the general population. And then their substance use disorder risk is a lot higher too. And 65% of people who have passed through a US prison report a substance use disorder issue. So that's 2/3 of people, which is a huge amount. Next slide, please. So when we think about the risks that people have and what risks increase at reentry, so I said 12 times the risk of death in those first 2 weeks post-release. The majority of that is due to overdose, suicide, violence, and injury. So these are the things that we should really be focusing on when we think about ways to help people, again, survive and also thrive. Next slide, please. So from the healthcare perspective, what things seem to make a difference at reentry? Go ahead and forward, please. We know that health insurance can be a huge barrier. So prior to the Affordable Care Act, people had their Medicaid, if they had Medicaid prior to going into jail or prison, they had it terminated. Thank you, Betty. Yep, having medications for opioid use disorder specifically. And I'll say Vivitrol, we can talk about the data behind the medications definitely, but with health insurance, the folks that were on Medicaid prior to the ACA had their Medicaid terminated when they would go in. And now states can suspend that Medicaid, which means that they can't use Medicaid when they're in prison or jail, but the moment that someone gets out, they don't have to do a full application again. They can call Department of Health and Welfare, they can call HHS and say, I am out in the community again. And that one call can allow them to have their Medicaid switched back on a lot more easily. Next, forward, please. And then overdose education prevention. Thinking about the risk of overdose, we need to make sure that people have the ability to keep themselves safe. And so that means Narcan. That means distributing it or letting people know where they can get it. That also means figuring out what medication is going to work for them. There are a lot more states now, thankfully, that are able to provide evidence-based medications for opioid use disorder specifically to people who are incarcerated. And we've seen huge decreases in overdose after release and also honestly like during incarceration because of that mission. The Rhode Island Department of Correction in 2016 started offering all 3 forms of FDA-approved medication for the treatment of opioid use disorder, which means they offered methadone, buprenorphine, or naltrexone. The buprenorphine was in film form, so it's Suboxone strips, and then the naltrexone was Vivitrol pre-release. And what they found is over those first 2 years of offering all 3 forms of MOUD, they had a 12% decrease in overdose deaths in the state and a 60% decrease in overdose deaths for people getting out. And so those were huge drops in overdose rates for a full state. And granted, Rhode Island's a small state, everything is like very close together. So implementing something like that looks very different than in a big state like Idaho that has lots of rural areas and not enough opioid treatment programs across the state to get people seen. But what they found was methadone and buprenorphine were the ones that were more associated with people's lives being saved. So how do we make sure that if we can't get people on those medications before they get out, that they get on those medications as soon as they're out? Next slide, please. And then, thanks. Sorry, I should say forward. Medications overall. So not just medications for opioid use disorder, but if you think about the chaos of reentry and all the things that people need to do, getting to the doctor is not high on their list. And so how do we make sure that people have medications for their chronic medical conditions like high blood pressure and diabetes that would stop them from having an ER trip? That's a really important one to be able to advocate for in any of these facilities. And so if you work with a local jail and you know that someone has been a patient at, for example, the clinic site you're at, and you know they're getting out the next day, the importance of connecting that person to either a telehealth visit the day they get out, or working with a provider and saying, hey, we can get this patient their medications because we know them, we've seen them within the last year, and so can we just send the meds to a pharmacy for them to pick up, can be a huge benefit. At Idaho Department of Correction, every person that releases gets 30 days of their medications in hand and a 30-day prescription for them to be able to fill. Jails don't have that ability because, again, they see so many more people coming in and out, and they just don't have the infrastructure to be able to provide that. So think about ways to partner with jails to get people the care that they need. Can you go ahead and forward, please? And then education. A lot of people that are coming into jails and prisons may not know about some of the health problems they have. And if they know about it, they may not have the education about those health problems that's going to help them be successful on the outside. If you think about things like if someone was diagnosed with diabetes when they were locked up, the type of diet they receive when they're in is going to be very different from the type of diet they have access to on the outside. And so what types of information may be helpful to share with people about this? And then next slide, please. And then this one's really big. And it honestly, it feels like it links to everything else. But how do we make sure that there's a warm handoff? And how do we support those linkages to care? These systems feel like they exist in silos. And so when someone leaves IDOC, they no longer get healthcare services from IDOC. They no longer get mental health services from IDOC. There's definitely better warm handoffs when it comes to the mental health services. But from the physical health perspective, we're not doing what we need to. So how do we promote more in-reach, which means how do we get community providers to be able to create those linkages of care? And I'm going to take a minute to talk about some things that other states are doing. So there's a Medicaid 1115 waiver specifically for the criminal justice system. And I think 9 states so far have applied and been approved for this, including Montana, Utah, Arizona, New Hampshire, Washington, Oregon, California. The goal of it is actually to provide Medicaid reimbursement for services 90 days pre-release for carceral settings. And what that means is that you can have community-based providers provide in-reach and be compensated for it and make sure that those warm handoffs really do exist in a sustainable way. For anyone that is interested in learning more about that, like please reach out, because I do think that it's something that would benefit our residents in Idaho. But there's definitely steps that need to be taken for that. Okay, next slide, please. So what barriers can we identify that might be healthcare specific for people getting out? I'm either happy to have people jump in to the chat, or I can just talk through them. But these are the photos are kind of hopefully inspiration for reasons that people might have barriers to accessing healthcare. Yes, exactly. Daniel said transportation. Betty said lack of providers. Perfect. Yeah. So the transportation one, that's where that Lost Springs comes in. In such a rural state, we don't have the luxury of a lot of public transportation that's accessible. And especially in places where there aren't enough providers to begin with, it can be really, really difficult to link people to care. And stigma too, totally. And then forms of ID. So those are all very helpful. For the forms of ID, if people don't have an ID, they cannot be seen in certain clinics because they can't prove that they are who they are. And I will say one of the things that more correctional spaces have started to use is to promote telehealth services for folks that are getting out. Some of the ways that there's been discussion within VA systems is, can we have telehealth services available to veterans who are getting out to be able to have a visit with their provider the day they get out, just on an iPad while they're meeting with a Veterans Justice Outreach specialist. So we have to think creatively about overcoming some of these barriers, and we have to also make sure that we're addressing the fact that, like, we have limited resources. The other thing I'll say too, and this is thankfully less of a problem than it was 10 years ago, but access to services and the cost of it can be immense for people if they don't have insurance. So that going back to Medicaid, if they qualify for Medicaid, how do we get them signed up, honestly, before they get out so that they can get it activated as soon as possible? And that's a question that we should be asking every person that gets out. What's your insurance? What's your plan for it if you don't have insurance right now? Because it costs money to get seen. Next slide, please. And then I wanted to talk about some barriers that we have at an institutional level. So that's more in the correctional setting, and ways that we from the correction side can and are trying to improve that. So I will say there's limited communication between custody and healthcare staff, and healthcare staff typically doesn't know when patients are going to be released, at least in jails specifically. And so when people work in correctional settings, those healthcare providers are usually not known in the community. So how do you figure out who the healthcare provider is in your local jail or in your local facility that's an IDOC facility? It's really important to, follow HIPAA and follow 42 CFR, but a lot of this is based on care coordination. So as soon as you figure out who that point person is in your local jail or in that, again, local facility that's IDOC based, connect with them, foster that relationship, because it can do a world of good in terms of getting you the information you need to take the best care of clients and patients. The other part too, if you could just forward, this goes back to that HIPAA/42 CFR. There's a lot of concern surrounding whether or not there's HIPAA compliance and having these conversations. But again, if it comes back to care coordination, those are appropriate conversations to be able to have between a community-based provider and a correctional provider. Next slide, please. So who's at the table when it comes to reentry/release? These are the people that I am always thinking of, making sure that if there's a complex discharge that's occurring, that we have involved. So it's case management, and this is specifically from the DOC side of things, the case management involved. Is there a discharge planner that's involved in terms of in-reach that is being done by a community health worker if they're available? Medical is both on the inside and on the outside. Are they communicating? Is there information that's being shared appropriately? Mental health, same thing, inside and outside. And then probation and parole for people that aren't topping out. And then really making sure to include family and all the positive supports that exist for people when they get out. And this can include peers. A lot of places, I see it more in departments of correction across the US, but I'm sure that some jails are doing it too. I know that some jails are doing it too, especially when it comes to addiction treatment. But utilizing peers who have lived experience of being incarcerated and of having addiction, and having them provide those really important linkages for people when they get out can make a world of difference. Next slide, please. So, who benefits most from support? What we've seen in many different settings is that people who have a serious mental illness or severe mental illness that is persistent, people that have a substance use disorder, and it seems like because of the risk of overdose and specifically due to opioids, that prioritizing people that have an opioid use disorder can be really beneficial in terms of saving lives. People that have complex physical conditions that require medical supervision, and then people that are living with HIV or AIDS, and people that are old. We have a lot more people that are over the age of 55 that are incarcerated. And with that aging population, they need more care when they get out. They have less support and less family around. And we've had people that sit waiting for some type of housing because they need a skilled nursing facility level of care, and there's no one to take them home. There's no skilled nursing level available for them that will allow them to be there. So those are the people that we start doing more work on earlier to make sure that their reentry could be more successful. The worst case scenario is someone, gets released and they just end up at the emergency room because there's nowhere else for them to go. Next slide, please. And in the last minute, I just wanted to give a couple examples of community collaboration. So next slide, please. Sorry, that's really blurry. The Transitions Clinic Network is a set of community clinics that have peers who have a lived experience of incarceration who work doing in-reach to make sure that people, when they're coming back to our communities, can navigate their healthcare system, can navigate their needs for housing, transportation, jobs. And transitions clinics across the US, I think there's almost 30 now, they've demonstrated reductions in recidivism, reductions in ER use, reductions in hospitalizations. And it's all centered around this peer with lived experience that works with people. Next slide, please. There are places too to address the risk of overdose that have naloxone vending machines that are in their lobbies for visiting and for P&P, which is really cool. And I think, don't quote me on this, I think that might be a plan for maybe one district in Idaho, which is great. But how are we making sure that people have these things that are accessible to them to, again, decrease their risk of overdose? And so the Center for Behavioral Health and Justice in Michigan has rolled out naloxone vending machines in multiple jails across the state, which is great. And then next slide, please. And I also wanted to just give a nod to these dually based medical teams where they have providers and full medical staff that work both in a jail and in the community. And so there's a really excellent jail in Ludlow, Massachusetts, and one in Hennepin County in Minnesota that have been providing services both on the inside and outside. So they contract directly with the jail to provide medical care and some behavioral health services. And then they get to see patients on the outside too, which has really improved the continuity of care and lets patients get to know a provider and then continue to rely on that provider if they go in or out. And then next slide, please. I'm not going to go through this slide. It'll be available, but these are just strategies to consider for enrollment into Medicaid and just how impactful they can be for folks. And then next slide, please. So this is my ask of all of you. Like if this is work that interests you and you feel like we have a need to serve folks who are justice involved, I would say that some of the things that we can all do are just thinking about ways to create those opportunities for partnership. So in community supervision, reach out to your local probation and parole office. So each district has a P&P office. You can also connect with your district treatment court. And I'm going to give a shout out to Sandy Jones, who's on here from the Supreme Court side of things. So if you have questions about treatment courts, you should message Sandy. And then for other ways to connect with folks, think about involving your local public health district to see what they can provide in terms of resources. For District 4, they do STI screening for Ada County Jail. And having those partnerships means that there's already a door that's open. So try and continue to open those doors to get everyone on the same page and make sure that, again, these transitions can be as smooth as possible. And then if you're thinking about jails and prisons specifically, and yes, every district has a reentry specialist as well, and that's through Idaho DOC. So there's a reentry team that exists, and they focus on not the healthcare side of things, but reentry specifically. So jails and prisons, know where your local facilities are. Consider reaching out to a case manager that's there. And then with Idaho DOC, connect with the local reentry specialist. and offer to help connect people with services post-release. So if you have a list of services that are available specifically for something like counseling, share that list with the case manager and say, hey, these are the places that we refer people to regularly, or we can accept people. What else do you need from us? And having those doors open, again, makes a huge difference for folks that are getting out. And then the next one is just references/resources. All good.
Awesome. Thank you so much, Radha. That was really great. A quick question from Betty in the chat. Do you have a resource list that can be given to those who are leaving jail/prison?
So Find Help is the one that we generally use. It's pretty comprehensive. I will say that the tough part about it is not tough, but everyone has different experiences at places. And so people talk about their experiences, and I honestly rely on patients' experiences to be able to know, what place are they going to receive really like patient-centered care, or what place is low barrier when it comes to getting started on medications. Thank you, Shannon. Yeah. So I think, sorry, I don't have a comprehensive resource list that I maintain, but those are kind of the ways that I think about it.
Awesome. I want to open it up just for a few minutes for questions and thoughts. I see Caitlin just put some information into the chat as well. Thank you, Caitlin. Questions? And to our audience members, you can either unmute or put your questions into the chat, but I will start with some of my panelists. I'll start with Chloe.
How much, so you said 2/3 of all people passing through the jails or the prison system have SUD, or are reporting some type of SUD. How much treatment is happening within the system? And do they get connected on the way out?
So it is a great question. For different substances, I think that it becomes really tough, and this is like me speaking as a physician. I think like the things that I can do to help people with tobacco use disorder and opioid use disorder in terms of medications are far more effective than anything that is like medication based for stimulant use disorder or even alcohol use disorder, where like there are medications, but they don't work as well as the like cognitive behavioral therapy does. And so the medications aren't really available at the same level they are in the community. So that's number one. And number two, I think there are groups that exist in a lot of spaces, but jails, for example, if the average length of stay is 3 days, then people aren't going to get into a group and be able to access counseling when they're incarcerated. And honestly, like the majority of people don't have a chance to be screened effectively and diagnosed and assessed for treatment opportunities when they're in jail because of that length of stay being so short in a lot of places. That's a great question.
Thanks for that question, Chloe. I'll do Natalia, Debbie, and Caitlin.
Thanks, Shannon. Radha, I really appreciate your presentation today. A lot of really good information. This idea of the dually based medical teams really sparks my interest. So working at Trivium, we are a major referral for those who are transitioning into the community from incarceration, and also work very closely with probation and parole. And I see a lot of difficulty that really gets in the way of my role of working with SUD and working on stability, reducing those risk factors. And if there's not the medication or there's health issues, that creates a huge problem and major barriers. And there's only so much that we can do and offer. So I'm curious what your thoughts are. I'm not aware that this is happening in Idaho. And what do you think that would look like? What would that take to get that even started?
I think there's a couple opportunities, and I will say, like, this is from the perspective of working with FQHCs and NFQHCs in the community. The extra level of staffing that it takes to work in a facility can be a barrier. And knowing that potentially you don't get to see the patients that you were set to see because of a lockdown or because there's not enough staffing on another level means that places that already run so lean because they have to, because they don't have the resources to introduce that extra risk factor, can be really difficult. And this is like this is me speaking as myself only. I think that some of the alternative payment models that exist to be able to pay like per member per month for all care to be managed by a community-based provider would be a really positive way to start. But that would mean like creation of totally different contracts and thinking through this in a very different way. So yeah, like how I think it like comes back to resources and like payment and making sure that patients can get seen. And if those needs can be met, then I would be really excited for community providers to like have that opportunity to go in and provide services. I think the other thing too is that there are multiple jails across the U.S. that do contract with local health centers to provide care. One of the biggest ones is Cook County Jail in Chicago. They've been utilizing CIRMAC, which is a local federally qualified health center, for 8 or 10 years now, and the care has really improved under that, which is very cool. And like the two I mentioned are on smaller scales, definitely. And then the other, Unity Healthcare provides care at the DC jail. So there are places that are doing it. And it would, again, like in a state where our resources are already spread so thin, especially when it comes to primary care services for low-income folks, it feels like we need to get the other parts like really right first before we can roll that out. And then every jail is different too, right? Like in a jail that has an average daily population of 5 for like less than 20, how do you guarantee that someone can like come in to see patients if they, one day there's no one at the jail? So
yeah, a lot of barriers there. Okay.
Yeah, but definitely happy to like through those barriers, because I agree with you. Like I think it would make care better in a lot of places.
Thank you.